Welcome to the Anxiety Disorder Screencast. I'm actually kind of anxious right now just thinking about delivering this screencast. But anxiety is a pretty common phenomenon that everyone should have felt at one point in time in their life. If you've never felt anxious or the sensation of anxiety, you are probably the odd one. So, anxiety as a clinical psychologist is a super common reason for referral. I mean, between anxiety and depression, they're kind of like the common colds of the psychology world. So what is anxiety? We can describe anxiety as someone that is inordinately apprehensive, tense, and uneasy about the prospect of something terrible happening. So the way I like to think about it is people that are anxious, their thoughts are kind of like anchored in the future. Somebody that's depressed, they tend to ruminate about stuff that's happened in the past, but anxiety kind of has this flavor of like worry and what's going to happen and what are the possibilities, and they're apprehensive, tense, and uneasy that something bad is going to happen in the future. Now, for my students in Wyoming, you probably know what this is. And maybe you've actually had an encounter with a grizzly bear. I have actually never seen a grizzly bear. I'm starting to doubt that they even exist. But we know they're out there. And when I go out in the backcountry and I have my bear spray, I am terrified of bears coming to get me. But is that anxiety? What is that sensation? Is it fear? What's the difference between fear and anxiety? Well, think about what happens when you see the grizzly bear. Imagine you're walking, I don't know, you're somewhere in Yellowstone and you're by yourself and you're hiking down a path and all of a sudden you hear a tree branch break or something coming through the woods, or a growl or a snort. What happens to your body? Think about what actually happens to your body. So you get an increase in heart rate, an increase in respiration, your blood pressure goes up. All sorts of things happen that you need to happen, you want to happen in response to that bear. And that's the fear response. So it's an innate alarm that's in response to a dangerous or life-threatening situation. Now, we could also call this a stress response, and I want you to think about that very carefully, because we only have one stress response. So this set of alarm responses to a dangerous or life-threatening situation would be exactly the same as you sitting in your car, safe and sound, in town, but you're worrying about the bills you have to pay, or your relationship with your significant other, or whatever it may be, will trigger the exact same stress response that we have. Whether it's a legitimate, dangerous, or life-threatening situation or not, we've only evolved with one stress response. And that's a division of the autonomic nervous system. There's two divisions. There's the parasympathetic and the sympathetic nervous system. Now, a lot of times at this point, students go, oh yeah, that's fight and flight, or fight or flight. And they think that that's two. No, actually, and pay attention, write this down, the sympathetic nervous system is fight or flight, or sometimes freeze too. Over here, the parasympathetic, I like to call this one rest and digest. So think about this word. This is sympathetic to the grizzly bear that's in the room with you. It's going to help you. It's going to help you stay out of trouble. You're going to have a reduction in saliva. I'll bet you've experienced that. Let's say public speaking is the most common fear or phobia that people have. What happens to you? Your mouth gets dry. Go watch Letterman or Jay Leno tonight, and all their guests are going to have a little glass of water on the table for them should their mouth get dry. Your heart rate increases, increasing your blood pressure. It helps to deliver nutrients to your muscles. Your bronchial tubes in your lungs dilate so you get more oxygen. Digestion stops because this is no time for digestion. The liver dumps glucose into the bloodstream. It's converted from glycogen into glucose in the liver. The adrenal cortex secretes adrenaline and noradrenaline, or epinephrine and norepinephrine. That's the American version of adrenaline. And then it inhibits bladder contractions. So that's a typical response in some humans. Sometimes the bladder does contract, though. We won't get into that here. But over here, this is the opposite. This is what slows you down. Okay? Everything here is built to either you're like hell-bent on killing something, or something is about to kill you. That's what happens. So the sympathetic nervous system response, if you understand that, that is the absolute backbone to anxiety disorders. Something's going on with the sympathetic nervous system. So the first one, panic disorder. You've probably heard people talk about panic attacks all the time. They say, oh, I had a panic attack before my final exam. No, you didn't. You just got really anxious and wound up. The thing that defines a panic attack is that it comes out of the blue. It's just like out of nowhere. And really what you're going to have people describe is a full-blown sympathetic nervous system arousal. So they're going to have increased heart rate, respiration, they're going to be sweating, and they're going to feel like they're dying. Typically they say they're having a heart attack, or sometimes you'll hear a stroke. Not quite so often with the stroke. Typically it's a heart attack, or they think they're going crazy. And so these panic attacks come out of the blue, and then people have this apprehension and worry about the possibility of another panic attack happening in the future. Sometimes these periods last for a short period of time. Sometimes the periods are longer. But during that period where you're having the panic attack, it's very discomforting. And people feel overwhelmed, like they're about to lose control. Like I said earlier, that they're about to die or they're going crazy. A lot of times people will call an ambulance or go to an emergency room while they're having a panic attack because they legitimately think they're going to die. Now, sometimes people develop agoraphobia with panic attacks. And agoraphobia is an intense anxiety about being trapped or stranded in a situation without help if a panic attack occurs. But, I mean, the typical scenario there is that they're afraid they're going to be in the mall. I mean, help would be there. So I want you to also add where escape might be difficult. I know that sounds weird, but people don't want to be in a public place or somewhere other than their house if they have a panic attack. And they'll develop agoraphobia, which is a fear of leaving your house. So you can have panic disorder with agoraphobia and panic disorder without agoraphobia. Now there's lots of different treatments. The biological perspective focuses on problems with neurotransmitter systems. The drugs that are used to treat panic disorder typically involve GABA, gamma-aminobutyric acid, or sometimes the SSRIs that target serotonin. So medications can work pretty good for a panic attack, but unfortunately it doesn't really get rid of the panic attacks at their root, so they'll keep recurring. And the medications, specifically the ones that affect GABA, which are called the benzodiazepines, can be abused. There's other psychological interventions for panic disorders that really work really pretty well. Now, when we talk about phobias, a lot of us have phobias. This is the one that I love to ask students about, and I get some really interesting answers. So students have lots and lots of phobias. A phobia is an irrational fear associated with a particular object or situation. A specific phobia is an irrational and unabating fear of a particular object, activity, or situation. So it doesn't go away. There's lots of different categories of phobias, like animals, natural environment, blood injection or injury, engaging in activities in particular situations, and a variety of miscellaneous stimulus. So personally, I've worked with people that have social phobia. I had a young man that I worked with that actually developed a phobia of doing math. That was really, really interesting. Clowns. I had a friend that I went to graduate school with that was terrified of shredded lettuce. Very, very interesting. So there's a clown, needles, spiders. But I want you to look at this list. I mean, there is a huge, huge number of phobias. Just look at some of these. Arachnophobia, you've probably heard of that. There's tons of them. Fear of gravity, that's a weird one. Fear of snow. Fear of clowns. Dogs, trees, cats, horses, and the list goes on and on and on and on and on and on and on. So those phobias are really easy to treat. And what you use is systematic desensitization. We've already talked about that. But what you do is you develop a hierarchy of stimuli that's distressing for the client. So let's say the girl that I knew who was afraid of shredded lettuce, her family owned a bunch of Subway restaurants. And I know this sounds crude, but she was eating a sandwich one day and she saw the piece of shredded lettuce and it reminded her of, like, again, I know it sounds crude, but like a booger. And so she saw this thing and she was like, oh my God, it looks like something that came out of somebody's nose. And she got grossed out. Right there, that's classical conditioning. So the lettuce didn't actually do anything to her, but it was paired with her thinking about, like, snot, and it made her sick. And that's just like Pavlov, the dog, the bell, and the saliva. So every time she saw shredded lettuce, she would get anxious. Now, here's the interesting thing. This is called Schachter's two-factor theory, and you have classical conditioning that comes in first to set up the phobia. Think about something else, like you touch a frog and it's slimy and it freaks you out. Classical conditioning. It's the slimy nature that grossed you out, but you pair that with the frog. Or you're with your mother, you're a small child. She sees a dog, and your mother screams and pulls you away from the dog. Well, it wasn't the dog that scared you, it was your mother, but that got paired with the stimulus of the dog. So, remember, unconditioned stimulus and unconditioned response means that happens naturally. So your mother yelling is an unconditioned stimulus, and the conditioned response is that you get scared. That is paired with a conditioned stimulus, or the dog in that case, or the shredded lettuce, or the frog, or what have you. And then the second part comes in, and that's operant conditioning. So remember Skinner? A reinforcement, that's anything that increases the frequency of a behavior over time. Now, there's positive reinforcers and negative reinforcers. Remember, a reinforcer, if you see that word, it's increasing the frequency of a behavior no matter what. Positive means you add something to get the increase in behavior. Negative means you take something away. So think about that girl and she sees the shredded lettuce and she gets grossed out and she feels anxious and she runs away from the shredded lettuce. It reduces the anxiety and increases the frequency of a behavior. So that's negative reinforcement. Think about the annoying seatbelt noise in your car that goes ding, 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 ding. That's like anxiety. You put your seatbelt on to avoid that. It increases the frequency of you wearing your seatbelt. So what we do in systematic desensitization is we create the hierarchy of stimuli that remind you of the phobia. So let's do dogs. The word dog, that would be like a 1 on a 10-point scale. A 2 would be a cartoon drawing of a dog. A 3 would be an actual picture of a dog. 4 would be a stuffed animal of a dog. 5 would be a video of a dog. 6 would be looking at the dog from a safe distance. 7 would be a dog in a cage in the room. 8 would be like a dog on a leash. 9 would be an unleashed dog in the room. And then 10 would be actually playing with a dog. So you go step by step up the hierarchy, but you teach relaxation techniques. So the client is able to calm themselves down so you don't have the sympathetic nervous system response. So remember, let's go up here. Where is it? Here. What you have when you get anxious is this, the sympathetic nervous system response. For those of you that have played sports, you know how to get pumped up, how to get this going. But a lot of us don't know how to relax. So we teach relaxation techniques that turn on the parasympathetic nervous system. And this is kind of like it's not exactly like a light switch, but it's more like a dimmer switch. Like this cannot be going while this is going. And you kind of flip-flop back between the two. So if we can figure out how to turn your parasympathetic nervous system on, you won't be anxious anymore. That's what the relaxation training is for. Flooding's really interesting. I like flooding. You might not like flooding. Flooding is when you're just exposed to the stimulus. I always like to think of somebody that's afraid of swimming, and this helps me remember flooding because of the water. You just take them and throw them in a pool. Let them freak out. And then pretty soon they're going to realize, like, oh, I guess I'm okay. And then they're not afraid of the stimulus anymore. I always think about taking that friend of mine from grad school and getting like a chipper shredder and throwing a bunch of heads of lettuce in there and shooting it all over her. That would probably not be ethical, but it'd be a fun way for me, at least, to help her get over her fear of shredded lettuce. There's imaginal flooding where you do it in your head. Graduated exposure, we talked about that with systematic desensitization, so step by step up. And then there's another process called thought stopping, where you realize that you're being irrational. Social phobia is a really, really interesting. If you think about this, you might know somebody that has a social phobia. I've worked with kids that have social phobia. That's an irrational and unabating fear that one's behavior will be scrutinized by others. It causes the individual to feel embarrassed and humiliated. The kid that I worked with that had social phobia, one of them, he would get to school like an hour early so he could go hide in the hallway so he wouldn't have to interact with any other students. He was a junior in high school, and he said that literally he had not spoken in 3 years of high school because of the social phobia. But, I mean, one-on-one, the guy was pretty normal. I kind of liked him. So the biological perspective, again, we go back to GABA typically for all the anxiety disorders, but serotonin and norepinephrine play a role. There's lots of different medications that you can use and different types of therapy. Generalized anxiety disorder, or GAD. So generalized anxiety disorder, Just listen to the name. It kind of tells you what it's all about. It's generalized. It's anxiety that's not associated with a particular object, situation, or event. It's a constant feature of that person's day-to-day existence. Obsessive compulsive disorder is another anxiety disorder. A lot of people don't realize that obsessive compulsive disorder is an anxiety disorder, but it is. And let me explain this to you so you understand it, because this is one of the most frequently misunderstood disorders. An obsession is a thought that a person has. It gets stuck in their head. They don't necessarily want to have it, but they think about it over and 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 over again. Now, the thought might actually be an image that pops into somebody's head. And for the TV depiction of OCD, it's cleanliness. But I want you to just throw that out and rethink this. The obsessions that people have can be about anything. And a lot of times, they're really kind of graphic or violent images or thoughts that pop into somebody's head. Now, I'm not preaching Freud here, but think about Freud's id. So violent sexual images pop into your head, or fears of contamination or something like that can be there. And it causes the person a lot of anxiety. So anxiety goes through the roof. The compulsion is in place to reduce the anxiety. So a compulsion is a repetitive and seemingly purposeful behavior performed in response to uncontrollable urges according to a ritualistic or stereotyped set of rules. So you have this violent idea or thought or image that pops into your head. Maybe you have the thought of your family getting run over by a bus. That should cause you anxiety. And now you need to figure out a way to reduce that anxiety. People come up with a compulsion. Remember, negative reinforcement. This is just like the bell in your car with the seatbelt. And when you perform the compulsion, anxiety goes away. It fuels itself. Now, it's not that obsessive compulsive disorder is just straight up a learned behavior. I mean, there's brain differences that you can see. There's a genetic basis for this. So it's lots of different things. I saw a young man. He actually had the highest IQ I've ever seen in testing. But he had these really, really graphic and violent sexual images that would pop into his head while he was in school. And his grades had recently taken a pretty drastic dive. But I found out what his compulsion was. It actually took a long time to figure this out. The young man was pretty reluctant to tell me what was going on. But the compulsion was that he would do really, really, really complex math problems in his head after he had the violent sexual images as an obsession. So he spent most of his day doing math problems, not paying attention in school. So obsessions that are time-consuming or that are really violent and cause distress, they can really be impairing in your day-to-day life. There's the bus. Think about that. What if you had an image of your family getting run over by a bus that went through your head, all day, every day? That would be pretty distressing. So there's lots of different dimensions of OCD, and this is out of the book. I don't necessarily like this. I want you to think about it like I just described it to you. But a lot of the obsessions are, they have to do with the iron is on. That should be an obsession that most of us have had. Oh my God, I think I left the iron or the stove on. And what do you do when you feel anxious about that? You go back and you check. Doing that, once a month isn't that big of a deal. What if that obsession was going through your head all day and every day? A lot of people, their compulsions have to do with symmetry and order, so they get things lined up or perfect. They might clean their house or wash their hands. Other people will hoard. So I'm sure you've seen some of the television shows about hoarding, and notice the obsessive compulsive nature in it. So it's definitely related to the obsessive compulsive disorders. The FDA approved treatments for OCD are all antidepressants, so serotonin affecting drugs. Acute stress disorder and post-traumatic stress disorder. PTSD. You know, that's really become very popular in our society, unfortunately, because of the huge numbers of young men and women that are coming back from the wars in Afghanistan and Iraq that have PTSD. So what happens with PTSD is that somebody has a very traumatic experience. This would be a disastrous or extremely painful event, and usually it involves like the fear of death, possible death, or confrontation with death. I mean, these are pretty significant events, but it could be just like serious trauma as well. You know, maybe someone is sexually assaulted or something like that. And the person will have severe psychological and physiological effects following that. So they'll have flashbacks and nightmares of the event. Acute stress disorder is diagnosed first. So acute stress disorder arises within the month following the trauma. It will last typically 2 to 4 weeks, not longer than a month. And the symptoms would include intrusion and distressing reminders of the event, dissociative symptoms. That's the first time you've seen that word. It's dissociative. A lot of people will try and put an A in there, so they say disassociative, and that's not the correct pronunciation. So say that, dissociative. And that's like an alteration in consciousness. Somebody might like black out for a couple hours and kind of come to consciousness and not know what they've done. And that's like without alcohol or anything like that. People will avoid situations that serve as reminders of the event. They'll have hyperarousal, which is the sympathetic nervous system being activated. And then full-blown post-traumatic stress disorder, the individual experiences the distressing symptoms for more than a month. So if there's a test question, and put a star next to this, where somebody's had symptoms for, let's say 4 days after a traumatic event, that's acute stress disorder. More than a month, post-traumatic stress disorder. And the symptoms fall into these 3 categories. Intrusions, which is those thoughts, and like the physical arousal symptoms, dissociation, we talked about that, and avoidance of stimuli associated with the trauma. We can see differences in the hippocampus in individuals with PTSD. I always tell my students, a lot of them don't think that PTSD is real. I am telling you it is very, very real. I want you to think of post-traumatic stress disorder as a brain injury. It's a brain injury that you can't see. However, research looking at large groups of people with PTSD has seen a reduction of the volume in the hippocampus. We use SSRIs to treat antidepressants along with psychological therapies. These are very, very important. I don't like just the use of medication in treating PTSD. Actually, a lot of therapists will prescribe a lot of other drugs that are probably very inappropriate to prescribe for PTSD, but the therapy is very important. So there's lots of different types of therapies. One is EMDR, This is actually Google this. Look this one up or read about it in your book. It's kind of interesting. So anxiety disorders from the biopsychosocial perspective, there's lots of different problems within the anxiety disorders. Some of them are learned, but some of them definitely have a biological basis. There's lots of differences and similarities in the symptoms and causes. We talked about how the anxiety disorders come about. In a number of cases here, I gave you examples. But what typically happens is that somebody's going to have a unique combination of genetics and life experiences that are going to combine, and you'll see the expression of the disorder. So, again, genetic predisposition. You're going to have a change in brain functioning. You have the right life experiences, which is typically a stressor or trauma of some sort, and in the right social context, you will see the emergence of the anxiety disorders. So again, anxiety is very, very, very common. If you haven't experienced anxiety, you're the weird one. Anxiety is something that we all have, but think about that fear response. So fear is something that we should have, but anxiety is fear that is out of check. Anxiety is fear that is out of proportion to the stimulus or inappropriate to the stimulus. That's how you recognize anxiety. Also look for somebody that's constantly worried about the future and they have that sense of apprehension or unease about what's going to happen. Their thoughts are anchored in the future. So, that's a quick and dirty version of the anxiety disorders. Again, as always, if you have any questions, don't hesitate to ask.